I see that the director of our hospital, Dr. Halbertal, is with us as well. So, Dr. Halbertal, do you want to say something? And I'll just introduce. I am a friend of Domenico, and he arranged this webinar. So, thank you, Domenico. Please, Dr. Halbertal.
Hi, my name is Michael Halbertal. I am a pediatrician, pediatric intensive care physician. I'm working at Rambam for 34 years, besides some episodes outside, and I'm the CEO of the hospital for the last year or so. And we are all facing this major challenge. You are in the midst of this, and we are in the beginning, and I appreciate your time to share some of the information.
You're very welcome. I also see a Dr. Weissman.
Yeah, Avi?
Yes. Yes. Good evening. Good evening. My name is Avi Weissman. I'm the Deputy Director of Dr. Halbertal that you just spoke to a second ago. I really want to thank you for your time. I am an anesthesiologist by training, and this is a very valuable asset to have during these days. So I'm waiting patiently to the beginning of your talk, and we'll be with you for the length of the conversation.
Okay, this is Carlo Trani. Can you hear me?
Hi, Carlo. Yes, I don't.
Hi, Filippo.
I don't see you yet.
Yes, I can manage to have my video, but I'm here. I can listen to you, and so I can join. I don't know if I can do something to have also my face on the screen, but I'm trying.
Yeah, you have to click this sort of camera at the bottom of the screen on the left.
I did.
We see you now. We see you now.
Okay, perfect.
Fantastic.
Okay, just having this in face. So, okay.
Okay, so our friends from Israel have already introduced themselves, so we can do the same on our side and then come to your questions. So I'm Filippo Crea. I'm the director of the cardiology. And so let's go around. Carlo Trani, Carlo, can you introduce yourself?
Yes, thanks to all. I'm Carlo Trani. I'm the head of the Cat Lab of the Policlinico Gemelli here in Rome.
And we have, Domenico.
Domenico,
Domenico, can you hear?
Yes. Okay. So
already Domenico has been the contact between the two institutions, and behind Domenico you can see Dr. Bischetti. Can introduce himself.
Hi, I'm Federico Bischetti. I'm an internist. My activities focused on the vascular medicine, but in the last month I fully involved in the COVID-19 situation, particularly in the art department.
Okay, now I think you have a list of questions in your slide. So if you agree, we can go through this list of questions and we'll give you our perspective.
That will be fantastic, thank you.
Yeah, before the list, perhaps just to give you some information about the pandemic in Italy. Now, we have this initial epidemics in outbreak in Lombardy region, close to Milan, and this was. Hi, by the way, Gianpaolo Nicoli is joining us. He's from CCU. I was saying that we had this pandemic in Lombardy region initially, and that was at the very beginning, immediately after the outbreak in China. And unfortunately, the infection was not recognized in 3 hospitals, which so became a sort of nosocomial infection. And that was the problem there, because this basically got out of control, and doctors, nurses, patients, friends all got infected. And this brought to these massive epidemics, mainly Lombardy region, where the situation is different from the rest of Italy. And also mortality in that region, because the system was overwhelmed, is higher. It's about 10%. It's almost the double compared to what is found in China or in Spain or in the rest of Italy. But the problem there was the beginning. I mean, they paid the price to be the first in Europe, outside China. And then once out of control, it becomes difficult to put it under control. In the rest of Italy and also in the rest of Europe and in the rest of the world, now we can afford not to be unprepared. Not to be unprepared means, as we always say, we are physicians, we love to say prevention is better than treatment. Now you are in the position of preventing before treating. So what the first suggestion is to get enough number of intensive care beds. The estimate, I mean, is quite easy because it's about 10%, and this figure is quite constant. About 10% of patients with clinical symptoms of COVID. Of course, we also have the asymptomatic patients, but it's a different story. But coming to symptomatic patients, about 1 out of 10 will need intensive care. And unfortunately, 50% of those reaching the intensive care probably will die. So the first issue is unless we let quick improvement in our way of treating. As you know, there is a wave of interest in torisizumab, which is an antagonist of interleukin-6, which can, the inflammatory response, as it happens in medicine, in many diseases, is overwhelming in these patients. An anti-inflammatory treatment in patients with severe involvement of the lungs, an anti-inflammatory treatment might work, but we do not have scientific data, just impressions, field impressions, which probably are true, something to keep in mind. So coming back to the prevention. So first of all, we have to establish what will be the number of people you expect to have the disease in your country, and you know that among those who are symptomatic, 10% will need ventilation. So you must be ready with that 10%. And then coming, so this is just a brief introduction of what's happening in Italy. Now, the second thing is lockdown. I mean, this is fundamental. We went through this first, so we warned the other countries in Europe that this was the way to go. But our politicians, I mean, we are fighting a war. The problem is that after the Second World War, we had politicians like De Gaulle and in the States, Eisenhower, and in Italy, De Gasperi, and so on and so forth. And in the UK, Winston Churchill, their division. I'm afraid that our politicians sometimes do not have so clear ideas. So we have to really make our job even more efficiently because they're not so prompt in understanding what's happening. So lockdown is the second important issue. It has to be perfect, no people around. Having enough ventilations and accepting the lockdown not later than after the 50, 60 deaths for COVID, having in mind these two issues very clearly, that helps a lot. In Italy, the situation is slowly, very slowly, but already improving, but very slowly. Now, this is the general picture. Now, let's come to the specific question. The first is patient triage during COVID days. I'd like to ask our friend Dr. Vicetti to address this issue. Federico, can you comment on this?
Yeah. So, yes. Just 1 second, Oren, could you please show down your slides? So we prepare, Federico prepares some slide in order to make easier how we triage this patient in our hospital. So he's not able to share his slides since there is this one on. Yeah, excellent. So let's try now.
Now you can share your screen. Domenico, you have to share your screen now.
Yes, we are doing that. Okay, just 1 second.
Yes. Okay.
Okay.
Can you see that?
Yes,
Yes.
I can
By
see
the way,
it.
you know Mauricio Foco?
Sorry?
Is it clear?
Yeah, we see.
Okay, please,
I
Federico,
think
you can
Professor
go.
Freya perfectly explained. Our situation became
Domenico, your microphone is off. We don't hear. Okay. No, it's off
Can you hear
again.
me?
Yes,
Now,
yes.
yeah. Now it's
Okay.
on.
Thank you. The very first cases recognized in the northern Italy in the first half of February was diagnosed after the second half, but probably the very January. And like Professor Crea said, probably the lockdown in this case is the only solution. At the moment, our numbers are shown in this slide. We have around 7,000 infected people with 10,000 deaths. Okay. The cure, like Professor Crea said, are quite improving, but the problem in our country is that probably the case fatality, that is double or more compared to the China mortality, is dependent probably to the because after administration policies, so probably the number of swabs is not correct. Okay, in our hospital, to respond to the COVID-19 outbreak, we change our organization in a few days. In fact, starting from March 9, every day an ordinary ward, in general the surgery wards, was converted in a ward dedicated to patients with suspected COVID-19 infection. At the moment, we have a total of 12 wards totally converted. And in the last 3 weeks, we evaluated around 1,000 people. And at the moment, we have 205 patients hospitalized, with more than 130 patients with confirmed infection. And the wards are organized in 15 single rooms with a team of 4 consultants and 4 residents trained for the particular attention to dressing and personal protective equipment, the PPE. As far as possible, regular medical wards were kept operating, although with a reduced number of doctors. The triage is organized in 2 paths. Okay, we have the first one when a patient is admitted to ER department without the suspect of COVID-19 infection, and is followed by the clean ER, okay, and admitted to the clean wards. Then we have a second part of the ER department, named COVID part, where the first swabs, nasal and oropharyngeal, and chest X-ray, CT scan, and the other exams are performed. And if necessary, the patient is admitted to the COVID wards, the 12 COVID wards. If the COVID infection is not confirmed, the patient is transferred to the clean wards. If the patient has the infections confirmed, is followed by the COVID wards, the infectious disease ward, or if necessary, the COVID dedicated ICUs. Okay, it's clear? Any question?
Just a small question regarding suspected patients that are not proved to be COVID-19. they get into the COVID-19 wards, and aren't you afraid that they will get infected, or how do you manage that? What do you tell them?
Okay, we have the first checklist performed in the art department that follows the WHO rules, but can you see the 3 points in these slides?
Yes.
At the moment, Italy is an endemic country. So the second update that was released days ago, so or having stayed in areas, is for Italy probably is northern Italy, center and southern. But in general, patient presenting a respiratory tract infection or patient with an acute respiratory illness or fever is admitted in COVID-19 path. So we have a lot of patients admitted in COVID wards. Sorry?
Yeah, please, there was some disruption. Please continue.
Okay. Regarding the time-dependent procedures, every patient is a suspect. So every patient is admitted to the COVID path. And after the evaluation, the cardiologist or neurologist is admitted to the coronary PCI or thrombolysis for the case of the stroke. And if stable, is admitted to the COVID time-dependent department. If not stable, to the COVID dedicated ICUs.
So just one question. We got a question from Azam. So if anybody want to answer from our side, from Rome, Azam is asking, do suspected patient wait in DR until getting COVID answer? So I'm putting maybe more words saying that if we are not 100% convinced that this patient is COVID, where this patient stay, in the ER, in the COVID area, or we are pretty much happy with the rule out that we have been done so far and sent to non-COVID path? Can somebody answer on that? Maybe Federico or Gianpaolo?
Gianpaolo or me?
Federico, carry on.
Okay. In general, the COVID answer is not enough, because the COVID diagnosis is a clinical diagnosis, and the swabs in general have a sensibility around 70%. And in general, we need also the chest X-ray or CT scan and the history of the patient. And we have, I think, around 20% of patients that have the first swab negative, the second one after 48 hours positive. So we need a lot of dedicated words, because we need at least 3 or 4 days to have the correct diagnosis.
If I may, another question. Do you use a lung ultrasound for screening patients, for screening symptomatic patients?
Yes, but not a screening. At the moment, we have several protocols, but it's not the definitive diagnosis. The infectious disease police are strongly believe that the CT scan is the definitive imaging to diagnose the COVID infection.
Yeah, I think this is a very important issue. The diagnosis is a clinical diagnosis, because now the picture is becoming quite clear. If the patient comes with pulmonary symptoms, cough in particular, and the chest X-ray is suspicious of interstitial pulmonary disease, and you can see the figures in the Lancet, I mean, they are quite impressive and quite typical. So if you have the picture of symptoms, chest X-ray, raised level of LDH, and low levels, low lymphocyte count, well, put all together, even if the pharyngeal swab is negative, that patient has to be categorized as COVID. So we, as usual, we have to be good physicians first. Then the swabs are important, but the clinical assessment of these patients also is important. Now, I'd like to make a comment on what Federico said. It is true, we have a growing number, but now we hope that will be less and less, number of patients in our main hospitals. But at Gemelli, we are lucky because we have this massive hospital with about 1,500 beds. It's one of the largest in Italy, but close by, 200 meters, we have a smaller building, and we have dedicated the smaller building to COVID, about 200 beds between sub-intensive and intensive, and all patients there are COVID. Then the initial idea was to have all patients there in this closed building, but unfortunately the number has been higher, so we are receiving these patients also in the main building. But I think it is important to make an effort in order to confine patients with COVID, suspected COVID, in the same area, in the same building, in the same wing, because the intermingling, no COVID and COVID, we are doing this, but ideally, I mean, if you have time to organize yourself, please avoid this mistake. All patients with COVID should be in a wing or building or whatever, clean patients, dirty patients. I mean, this separation is important. If you have time to arrange this, is very important. The second thing, which is, I think is official from today, Carlo, Domenico, Federico, is that we have rented a hotel. Close by, we have a big hotel, and of course, hotels are empty now in Rome and in Europe, because patients after the initial assessment, or patients who have low symptoms, these patients can really be managed with few doctors and few resources. It is enough to monitor oxygen saturation on the finger. And these patients, which do not need a high intensity or intermediate intensity assistance, they can stay in the hotel. The idea, again, is to concentrate patients with COVID or suspected COVID in the same area, and if possible, in the hotel with low level, low intensity care. If you're in the process of organizing your institution, your hospital, please consider these two possibilities. Put patients together, not intermingle with non-COVID patients, and if you have an hotel which can be paid, rented, whatever, consider that opportunity. Now, coming to the
question. We have several questions, Filippo, if we can. That's okay. We have several questions. Just
yeah, sure.
We'll stay.
Okay. Yes, let's carry on.
Yeah. So I just will say that our hospital has now a small building that most of the COVID-19 patients are hospitalized in, and we are preparing, if and when that we will have more, to have an underground hospital, totally separated from the above-ground hospital for COVID-19. We have the largest fortified hospital, underground hospital, at least in the Middle East. So Nati Horowitz, who is heading the program of preparing this hospital, asked what is the chance that a negative COVID-19 patient will be admitted in the COVID ward and acquire the virus, according to your experience? Did you have this kind of a scenario?
So I think that Professor Kerr already answered this question a bit. This is something that should not happen. So all the efforts should be put in order to avoid this kind of chance, because this will really imbalance all the pathway that you are building on. we have some case?
No, at the moment we are not case because we have totally separated paths, totally separated personnels, wards, CT scan is totally separated. At the moment we have no for this kind of chance, but obviously it's possible.
So I think that what we are trying to say is that all the screening should be done in the emergency department, and then the patient will be reallocated when the definitive diagnosis is done. So you really would like to avoid any kind of overlapping between COVID negative and COVID positive patient. Then there is another question from Emily, which she asked whether do we isolate patient and use the same personal protection in the clean ward?
Unfortunately, no, because in the clean ward we use the WHO suggestions, so the mask, gloves, but for the COVID wards we have a different level of protection, because if you have a suspect for the WHO suggestions, you have to use the mask, glasses or shield, gloves and gowns, and only for the confirmed or the aerosol generating procedures you have to use the FFP2 or FFP3 mask that are the N95. But in the clean wards, unfortunately, at the moment, we can use only the normal masks. So it's different, the level of protection between the wards.
Of course, in the real world, we should have all doctors and nurses should have the PPE protection, and all patients should undergo the swab. But I mean, this is not the case because numbers are so large, everything happens so quickly that what we have is an approximation. But I think it is a reasonable approximation of what might be perfect.
Can I ask a question?
Yes, sure, Itai. Itai is adding that to triage preparation.
So I just to be clear, you triage them based on the WHO criteria clinically. Am I right?
Yes. The clinical assessment is important.
So one pathway is the clean one, and the other one is the suspected one.
Yeah.
And now if you have once you have all the patients in the ED, before they are admitted to the ward, they have to be confirmed. Is that right?
Yes.
Okay. Now it's clear.
No.
Okay.
No. The diagnosis in general not confirmed in the other department. The patient is admitted in the wards, and the first swabs, generally we have the report after 6 or 8 hours, and so it's not sufficient to have the diagnosis.
So my guess is that you had plenty of cases where a patient without COVID-19 was admitted to a clean ward and then becomes positive.
Yeah, what is Manal Habibi from here ask? What is the percentage of that?
No, it's more the opposite.
Oh, okay.
The opposite.
Patients go to the COVID because, of course, with the criterion is a high index of suspicion. Okay. So patients who suspected go to the COVID ward, and of course, one in each room. I mean, we do not have patients.
Makes sense.
So if the suspect is there, but the diagnosis is not final, then the patient goes to COVID because we suspect. Doctors are protected, are fully protected. And then once the thing is clarified, then the patient either stays within COVID ward or goes to a non-COVID ward. And the percentage, Federico, is about 50%. I mean, COVID is confirmed in about 50% of patients with suspected COVID. Okay? Do you confirm, Federico?
Yes, yes, I do.
Okay.
Okay.
So we have a sort of, let's say, of migration from COVID to non-COVID. But what is important is the high degree of initial suspect.
Right. Thank you.
Perhaps we can ask Carlo Trani to tell about the pathway of patients with STEMI or non-STEMI, which is a critical issue in cardiology. Carlo, can you comment on this?
Yes, Filippo. Well, this is a moving target because can you hear me? Can you see me?
Yeah, we hear you, Carlo.
Okay. Because I mean, we try to treat every patient coming from the emergency as a suspect COVID, because it's difficult to have a complete history of those patients. And so, but you know, are time-dependent pathways. So it's not possible to have the swab for these patients. I mean, we don't have the result of the swab from this patient. So what we do, we try to treat this patient as if they were COVID. So we don't want to have this patient in the cath lab as far as all the stuff is completely done. And we treat every patient like a COVID patient. And then, as Federico showed before, if the patient is stable, even if it is a STEMI patient, it goes to a semi-intensive ward that is a ward where Federico works, that is equipped with telemetries, and in which we are, as cardiologists, work as consultants mainly. And if the patient is unstable, they go to ICU. The ICU, I mean, usually not CCU, is in general intensive care unit. And when we have the swab result, the patient either stays in the ICU or comes to the CCU. I saw a question on the panel regarding the semi-elective patients.
Yeah,
this is another tricky question. And today we finally had the resolution to have the swab.
We lost you?
Oh.
Carlo. Press, I mean, you have pressed the button. Okay, now it's fine.
I don't hear you.
Carlo, you with us?
We see you.
Yeah. Okay, and you hear me?
Yes.
Yes.
Yeah, I was just talking about the semi-elective patients. Did you understand me?
Yes.
Can you repeat it, please?
Yes. We had this resolution today to have the semi-elective patients with this pathway. When the patient comes to the emergency room, or if it comes from his house, of course, if as a semi-urgent indication, not a very elective indication, we do the swab, and when we admit the patient, preferably in a single room, and we wait for the swab result, and if the swab is okay, the patient goes to the cath lab. If the swab is positive, the patient goes to the COVID hospital, COVID ward, and then we do the cath lab.
Okay.
So more thrombolysis these days?
Yeah, I was coming to this issue to give you a broader perspective. This is the line of reasoning we have been following. There are two options. One for STEMI in particular. One is to go back to thrombolysis. And in China, in the Wuhan hospital, this was their choice. in other institutions are going towards this direction, which means to give thrombolysis. I mean, it's the pharmaco-invasive approach. What happens when a patient goes to a hospital without cath lab and the time to transfer the patient is more than 2 hours? So, well, what we do everywhere is to give the fibrinolytic agent and then PCI. So one option we had was to go for this approach, pharmaco-invasive thrombolysis. This gives the time to understand more clearly the patient you have in front of you, if he's positive with the swab or if it is severely symptomatic. I mean, if it is a risk patient, then you know that you have time to organize yourself. So one possibility is to go for fibrinolysis and have the time for a full assessment of the patient. The other option is what Carlo told you. We go for primary PCI, for emergent or urgent PCI, but we consider that particular patient as a COVID patient. You don't, I mean, the default is that you have to consider that patient is a COVID patient, which means that you must have enough staff to get protected from the patient. Now, my personal inclination initially was to go for fibrinolysis, to have more time and understand better what happens. Then we went for the second approach, what Carlo told you before. I mean, no primary PCI, but with full protection. And the reason why we went in this direction is that the number of STEMI patients, and this is a global problem, the number of STEMI patients we see, of patients with MI we see, is much less than usual, probably because many of these patients are scared of coming to the ER, to the hospital, and they unfortunately have the infection at home. So we had a reduction of patients coming to the cath lab, first because emergent patients are less than usual, and second because we have stopped the admission of elective patients. So this gives us more time for the cath lab, and this is why we can afford to pay the price of considering patients who come to the cath lab as COVID, because this means not only preparation of the doctors with full protection, but then the room has to be cleaned, which in our institution takes about 3 hours. So the approach of delivering primary PCI and emergent PCI to all patients is affordable because the overall burden of patients on the cath lab is less, but the price to pay is that operators and nurses have to be fully equipped, fully protected, and the cath lab has to be cleaned after these patients.
Yes,
may I add something?
If I can add just one word, sorry. For these patients, we double the staff during the off work. I mean, we generally are one physician, one nurse, one technician. Now, when we have a patient with STEMI, we double every figure. 2 doctors, 2 nurses, 2 technicians, because, you know, we want to be more quiet, more cautious in these patients.
Yeah, you had to take many more precautions. So doctors on call for the cath lab are doubled, and the same nurses. And it is working pretty well.
Okay.
May I add, sorry, add a comment. There's been a survey coming from the Italian Society of Cardiology comparing 2 weeks. 1 week, the last week in March 2020 versus the same week 1 year ago. And they show basically that the number of acute coronary syndromes were reduced by 50–60%. Especially non-ST elevation MI. So Professor Krea was right, and but probably more non-ST elevation. The number of STEMI is quite the same, but the number of non-ST elevation MI is very reduced.
Coming to STEMI, another interesting thing which is coming up, I've not seen published papers, but this is an observation which seems to be consistent, is that when a COVID patient, confirmed COVID patient, so he comes because of COVID, and then he develops STEMI, well, in more than 90% of these patients, there are no obstructions. So it's a minoca. When it happens to STEMI patients who come for COVID, it's a minoca. And in these patients, of course, it's not wise to give thrombolysis because you pay a price.
I would not exclude that in this case, as probably is the same pathology at the level of the lung, there is an involvement of the microcirculation, but a thrombotic involvement of the microcirculation, because some post-mortem data coming from Bergamo show that there is a vasculitis involving the microvessel of the lung. So probably it may be the same at the level of the heart. So we cannot exclude that there is a microvascular involvement, thrombotic involvement in this kind of patients.
And actually, there is a nice study which will be published soon from Andreas Zeyer from Frankfurt, showing that this famous ACE2 receptor, A2 protein, which is present in the lungs, and this receptor for the virus is also expressed in the heart, in particular in the endothelium. Apparently patients with heart failure, for instance, have a higher expression than patients without heart failure. So these are data not published yet, but they will be published soon, which means, in other words, that as cardiologists, we will be heavily involved because the cardiac involvement in this patient is not the exception.
I want us to shift to non-cardiology issues because we have all the hospital staff online with us, and we have a question from our ID, Nasrin Ghanem, and she's of course interested about healthcare workers' infection and transmission, and this is important for all of us. So what are the type of the precautions you are using, and did you miss the diagnosis of COVID in healthcare workers, and how do you handle that?
Federico, again, you are called into action.
At the moment, we have 4 infectivologists infected, and in a number of, I think, 40. So it's not a great number, but we have also an entire ward of gynecology with 3 or 4 nurses and 1 doctor. But it's important to note that this kind of personnel was not the personnel involved in the COVID ID management, because the gynecology department in particular was the normal gynecology department, and probably the PP that we are using, the COVID-19 ward, are enough to protect the personnel. The problem is in the clean wards, like Professor Kerr said. So we use the WHO issues, and you have to know that the CDC from US and the ECDC are quite different, because WHO suggests only the normal mask for the suspect and also for the confirmed cases without aerosol generating procedures. CDC from the US, from Atlanta, and the ECDC are not agree, because they suggest if you can use N95, that is the FFP2, if you can. If you cannot, use the normal mask. But at the moment, we use the WHO suggestions, and the number are not important at the moment.
Coming to doctors, in Italy, 10% of COVID patients are doctors. So we are paying a price which is not negligible in terms of people who have the disease and also colleagues who died. So this is a price to pay. But this price can be kept as low as possible just by complying with these simple rules. And in particular, as Federico said before, the issue are not COVID patients, because we know how to protect ourselves from COVID patients. The issue are patients who are asymptomatic, not suspected COVID, because again, we are cautious when we suspect COVID, but it's the asymptomatic patients. And we know that you can be totally asymptomatic before and shed the virus. And this is why we have to consider the others, patients, nurses, or friends, or whatever, all of them as potential COVID. I mean, this is the simple rule of thumb. And this study published in The Lancet, which is very interesting, showing that the shedding, viral shedding in patients who are asymptomatic is similar to that of patients who are symptomatic. And this is a major difference between influenza and COVID. With COVID, the ability to infect of asymptomatic people is remarkably high. Now, I can see that there are about 70 participants to this video conference. So yes, perhaps this, the opportunity to welcome all your colleagues and friends is a great pleasure to meet you. And really, we hope that our experience, our sad experience, can be of help to the others.
And we really appreciate your help on that. And thank you so much. Another non-cardiology question, Zila Zuckerman asks, what do you do about ambulatory patients? She's heading our hematology department that are immunosuppressed. And if you have to hospitalize them, what do you do next? So the issue of ambulatory services is a big issue. And did you reduce that? Did you modify your strategy?
We basically stopped, both private and public. I think that really in this period, the priority is to COVID, and all people who come without an acute reason, people who are not urgent or emergent, if they come to the hospital, they run the risk of being infected. It is clear by now that hospitals are the main source of contagion, obviously. In particular with lockdown, I mean, with good lockdown, as we have now in Italy, the probability of spread the contagion in the city, in the streets, is close to zero. So the main source, in particular in the presence of lockdown, the main source of contagion are the hospitals. So less patient as possible, and also less doctor as possible. I mean, as there's an overall reduction in the number of patients, because we do not admit elective patients, outpatients are closed. So the number of doctors which is needed is frequently less than during the daily life. And my strong suggestion to my colleagues in my department is to stay home if they're not needed at the hospital, because we love our work, we have a passion for what we do, and we tend to stay at the hospital just because we want to be part of the team. And this is wrong, this is a mistake. In this case, we have to reason. I mean, emotions should be left outside. So the motto is less patient as possible, as less doctor as possible.
Just Oren, just to add you something. The only thing that has been done was also an institutional effort to implement some kind of telemedicine approach, meaning that for some disease like heart failure or for oncological follow-up, the institution is providing a digital platform in which the patient can log in and look for their physician and either book a kind of Skype or Zoom teleconference of 15-20 minutes in order just to discuss some case or some symptoms. But this is something that we are developing, is not there yet, but is something that you could consider for chronic disease patient, like heart failure, for example, that is your focus and my focus as well.
Yeah, we are already doing some WhatsApp video clinics. So this is how we adapt to that. Avid, you have a question about, you have a very provocative question about hyperbaric oxygen.
I saw some information from China, but regarding the hyperbaric chamber.
Gianpaolo, can you comment on this? Hello?
Sorry, can you repeat about the question?
The question, yes.
Hyperbaric treatment in these patients. Are you aware of studies published?
I have no idea. I have no idea.
Okay. And
no, usually in the CCU, what is very helpful, especially for cases of IRDS, is the pronation of the patient, very early pronation of the patient. Yeah. I don't know why, but in many centers in the north of Italy, they used to prone very early the patient, and in some cases there is improvement. There are two parallel problems probably with the COVID. One problem is the lung, but the other problem, which can appear after usually 10 days, is due to a massive activation of macrophage, release of cytokine. So in this kind of patient, you can have at the same time respiratory insufficiency and vasoplegic shock. So it's very, very difficult situation. And in order to prevent this kind of situation, the interleukin-6 antagonist may be useful.
I see another question. If a patient deteriorates, do you consider ambu ventilation, or you absolutely forbid it?
Do you consider?
Ambu ventilation, manual ventilation.
Yeah, of course, but you know, in this case, the ventilation is longer. Usually the patient stays in the CCU for weeks, 1 week, 2 weeks, if he survives.
I think that
for the acute scenario that patient deteriorates and the risk for spreading the virus from aerosols when you ventilate with ambu. This is the question. Do you use ambu ventilation?
Of course, there is a risk. Of course, there is a risk. So this is the reason why, and this is another information that we gain from the north of Italy. They used to intubate very, very early, even if the patient is not so unstable, in order to reduce the possibility of virus shedding.
Yeah, this brings me to issues. One is the really establishing when is the optimal time for intubation, and this is mainly based on monitoring of oxygen saturation. When oxygen saturation drops, that is a clear signal that the situation can evolve very rapidly. Yeah. The second thing to consider, I'm not aware of published data, but again, prevention better than treatment. Non-invasive NIV, non-invasive ventilation, is something which perhaps should be implemented earlier in the natural history of these patients, but considering that you spread the infection. So, I mean, if you do it, you must be aware, do it in a way that prevents spreading of the infection, but early. And you know, this makes sense because once the alveoli are collapsed, it's difficult to re-expand them. With NIV, you may prevent alveolar collapse, and this might perhaps avoid the transition towards invasive ventilation. So it's something to consider, non-invasive ventilation early in the time course of the disease, but considering that you can spread the virus.
There is an algorithm that has been produced in Brescia, and we can send you this algorithm for the management of ventilatory part of these patients. I think it's very helpful. I can ask Domenico to send you by email this.
We will be happy to. We have
yeah, Oren, I will share you these documents and also the slides that we have been showing to you so far.
Yeah, fantastic. We have a platform, a Blossom platform for the Rambam guys that we put we aggregate all the data so it will be available for everyone. Another question about healthcare workers from Majid Kasum. Do you regularly screen healthcare workers for COVID-19 with swabs or something like that? Do you have this strategy or you don't?
Domenico, do you want to answer?
So it's very tough question because, of course,
this is why I asked you to answer.
Yes. So, of course, one of the key issue and is key for all the path is to protect the healthcare worker. So, of course, the first is to prevent the infection. I've been discussing so far how we can do that. On the other hand, there is a pressure, of course, also from our side to perform screening to all the personnel involved in the hospital during this COVID infection. Although there is a consensus on that, in the real world, this has not been done so far in all physicians, but just in physician or healthcare workers that were exposed or show symptoms related to COVID. This is the approach that had been used in Italy so far. And this was mainly based on some constraint about the number of swabs that were available, not really about because there was a general consensus on doing that in all the healthcare workers involved in COVID hospitals. But so far it's been done just in patient exposed or symptomatic for COVID. But I think in the next week, this will be enlarged to all the healthcare workers involved. Also because, I mean, you know, maybe more than we do, there are many hospitals and also university and industries involved in developing early markers of COVID infection for diagnosis purposes. So I think this will be much easier in the next week, but so far this is the picture we got.
Okay, thank you so much for that. Regarding risk stratification, Dov Tiziano asked, what do you use for risk stratification? How do you, discriminate between patients that need ICU and non-ICU, or maybe, more intensive or less intensive care? Do you use dimer, lymphopenia, any other issues?
Generally, we use analysis. And when we have a P and F ratio that is around 100, the ventilation, the trial of helmet is required. And generally, after 1 or 2 hours, if we have not response, the early intubation is needed.
Coming to risk factors, to predictors of risk, we are receiving several papers from China, and now the picture is getting a bit clearer. The risk factors are definitely hypertension. For some reason, hypertensive patients face a worse outcome. And also, interestingly, troponin raise is a risk factor. When there's some sort of injury to the heart, these are not infarctions because they do not come with chest pain or ECG changes. But hypertension, raise in troponin, and raise in CRP, and raise in BNP, all these biomarkers are risk factors. which means that the outcome will be worse in these patients with high levels. Now, when to intubate the patient, again, the guide, symptoms, and importantly, the oxygen saturation.
Regarding the presentation with cardiac symptoms, do you see many patients with presenting initially as myocarditis without respiratory symptoms or severe respiratory symptoms?
No, I think this happens, but I'm not impressed. This is a minority. And also a minority of patients who present STEMI, as I said before. And when they present STEMI, usually normal arteries are patent, are not obstructed. Federico, do you have comments on this issue? What in your experience?
At the moment, we have a patient presenting like a STEMI and actually has a myocarditis. Yes. It was admitted yesterday.
Presentation was ST elevation, Federico?
Yes. Diffuse ST elevation, troponin very high, and Carlo Tani performed the coronography, and he found the myocarditis. Yeah, also this patient, I have seen the...
Carlo, are you there?
No, he left, but I know the case because I was in the
Did you perform a stelcholine?
No, but the reason why it was not performed, is that the LV angiography was done, and there was a typical microaneurysmatic area in the inferior wall. So this was considered enough, considering the presentation.
I think it can be myocarditis, but you remember, Schultheis published this long ago. There are patients with myocarditis and symptoms, infarction-like symptoms. And in these patients, the reason why the presentation looks like more infarction than myocarditis is this happens in particular with parvovirus B19. And the reason is that this virus lives in endothelial cells, but also COVID can live in endothelial cells. And if you go for acetylcholine and is strongly positive, you have also a signal for the treatment. These patients go better on calcium antagonists.
Yeah, I think that should be done. I was not there, but I've seen the angiography, and this is what they refer to us. But I think it's a key to exclude also the contribution of the vasomotion. Yes, of course.
There are many questions about immunosuppression and specifically on IL-6 antagonist tocilizumab. So can you elaborate more about your experience with this drug, and specifically when do you initiate the therapy? Or do you do it only for ventilated patients with ARDS? Do you do it beforehand? Please.
So just, yes, then Federico will add some data that we are collecting here. This was a very early trial that was done by some colleagues in Naples and also other part in northern part of Italy, and our regulatory agency really was in this case very fast to approve a trial that is actually ongoing in this patient using this kind of drug. We have some experience with, and now Federico maybe.
Yes, yes. In the entire, the overall worlds of the COVID-19 worlds, we treated 89 patients with tocilizumab or sarilumab, Kezzara, because tocilizumab is not available at the moment because it's fully for the enable trial. So we have treated around 60 patients with tocilizumab, IV tocilizumab, and around 30 patients with sarilumab. And the results are very good and similar. It's not complicated data, but we are going to publish because sarilumab is not an IV composition, and this is subcutaneous administration seeing, but we used in 30 patients without any problem about administration and with good result. I mean, the endpoint was the admission to the ICU wards, and we obtained an important reduction. We have not slide or statistical analysis at the moment, but very important results.
Well, I think that in this setting, clinical impression is also important. Of course, we trust trials, we love trials, we rely on trials, but sometimes and this is the case, we do not have time to run them.
When do you specifically initiate tocilizumab? Only on ventilated patients or patients? No. Okay.
No, we will try to prevent intubation. So when we have a severe pneumonia, when PF around 80 or 60, and when sepsis is not confirmed, when we are not in neutropenia, when we have not infection, the cutaneous infection, we administer tocilizumab or sarilumab.
Do you base the choice also on PCR? Sorry, CRP, reactive protein.
We use PCR, the D-dimer, and the level of IL-6, because we can test. And generally, this patient have around 100, 200 picograms of IL-6. But, you know, the clinical impression, the clinical assessment is more important. Generally, the first report about the IL-6 level are not available when we start the first IV injection.
Yeah, but C-reactive protein is an excellent surrogate because, as you know,
yes,
interleukin-6 stimulates hepatocytes to release CRP. So I think that if you have indexes of inflammation like CRP, or SAA or fibrinogen, which are high, well, this means that anyway, the axis, the interleukin-1, interleukin-6 axis is activated.
Is the same, yes.
Okay, other questions?
I think two final questions. We don't want to take your precious time. So Arthur Kerner, who is an interventional cardiologist here, ask whether the degree of fever is a predictor for the cytokine surge and the cytokine storm.
No.
No.
No. Generally, they have not fever, because the fever is the beginning of the disease. We have a lot of patients without fever.
Okay. And another question from Johnny is, how many patients are being treated with hemodialysis in your institute? With COVID-19?
Starting with a trial for the phoresis, but is not ongoing at the moment.
Okay. Okay.
Okay.
Any experience with VV ECMO for these patients?
No.
No.
In the department, yes, there are some
Paolo,
patients.
Comments on ECMO in these patients?
Of course, it's the venous ECMO, not the venous.
VV. Yeah.
But this is an extreme therapy. But if you consider that many of the patients in the north of Italy, the situation was dramatic. So many patients with a lot of comorbidities did not reach this kind of approach, unfortunately, because they have to concentrate also other efforts on younger people. Do you understand? There is a document coming from the CRT, which is the National Association of Anesthesists, which has been has been discussed a lot about the ethical implication of this pandemic. Because in the north of Italy, the situation was really dramatic with so many patients coming to the hospital without ventilation. So thinking about venous ECMO in some cases was a dream.
Yeah, I understand. Totally understand. And we are also limited in the numbers.
But again, ventilation is the key issue. I think that if we manage to have ventilators for all of these patients, we have done our job.
Yeah, okay. I think if we don't have further questions, we will thank you so much. If someone... Okay, Avi, please.
I would really like to thank you in the name of all the Rambam physicians, a lot of other physicians from other hospitals in Israel. A lot of people are going to view this, and I'm sure we're going to implement the wonderful tips that you gave us. So thank you again for your time. Thank you.
It's been a pleasure for us. My best regards to all our friends from Israel.
Thank you so much. We really appreciate it. Thank you, Domenico, for organizing this.
Thank you, Oren.
And we will meet for a beer next year in Rome. Okay.
Yes, we need definitely to meet.
Okay. Bye-bye, my friend. Bye-bye.
Ciao, bye-bye.
Bye.
Tante grazie, tante grazie.